Introducing Dr. Ravendran Kisten. He is a distinguished neurologist practicing in private practice in Mediclinic Midstream in Gauteng. He did his undergraduate and postgraduate training at the University of Pretoria and has a profound commitment to understanding and treating complex neurological conditions, including immune-mediated encephalitis. Thank you.
Okay, good morning, everybody. So we're going to do a small talk on a brief overview on the autoimmune and paraneoplastic encephalitides. Okay, so just as a point of introduction, we need to talk about what is encephalitis. So encephalitis, the word itis means inflammation. So it has to be an inflammatory issue that's happening with the brain. So by encephalitis, there has to, by definition, be some sort of inflammation either on imaging or on CSF. So when we're talking about these autoimmune and paraneoplastic conditions, they're both immune mediated. However, they're quite different in terms of their pathology. And also because of that, their response to treatment is also quite different. So in general, the paraneoplastic encephalitis, they tend to involve the intracellular neuronal protein. So on what they know as onconeural protein. So even though we test for antibodies, these antibodies are directed towards intracellular proteins. Versus what's termed autoimmune encephalitis, they target cell surface or neuronal cell surface and synaptic proteins. And paraneoplastic encephalitis, very high association with malignancy. So even if you don't find it, you're going to keep looking. Versus the autoimmune encephalitis, which can sometimes be associated with malignancy, but not all the time. And clinically, there's two things that you need to keep in mind, is that each specific antibody tends to have a specific phenotype or a multitude of phenotypes. But also then if you go backwards and you look at the phenotype, then it leads to sort of a differential diagnosis of which antibodies we should be thinking about. To try and make it more academic and try to avoid false positive testing and false positive results leading to mismanagement. Yeah, I'm just trying to figure out. There. Okay. So first we're going to talk about the paraneoplastic encephalitis. So these are just a reminder of the intracellular. And the encephalitis is part of a broader picture of paraneoplastic neurologic syndromes. And I suppose it's even, and that's part of an even bigger picture of other paraneoplastic manifestations of systemic disease. We also have skin manifestations, etc. But in terms of the neurologic presentations, you can have peripheral nerve and peripheral muscle issues. And then you can have visual problems, optic neuritis, etc. And in terms of the CNS pathology, you can have cerebellar issues, you can have an encephalomyelitis, brainstem limbic encephalitis, etc. So these are just one part of a whole spectrum of paraneoplastic manifestations. So if we're talking specifically about the paraneoplastic encephalitis, it's important to realize this, that more than 50% of patients will present before their cancer diagnosis. It can be weeks to months, usually, and most commonly it's small cell lung cancer. So, and usually at the time of diagnosis, there's always, or 60% of the time, so majority of the time, is some sort of metastasis. So there is survival benefit if we can diagnose these cancers earlier. So from a neurologic point of view, patients will present with an acute or subacute presentation, implying days to weeks. And you have different phenotypes. So you'll have a limbic or brainstem encephalitis. We'll go through them now. You can have what we call a paraneoplastic encephalomyelitis. And in general, as we said, the CSF must show some inflammation. So you'll have a pleocytosis, and your protein tends to be up And if you had to do your oligoclonal bands, you'll also find them being positive. So limbic encephalitis, so that involves the, anatomically, the hippocampi, amygdala, hypothalamus, the cingulate gyrus, and the limbic cortex. So the presentation revolves around dysfunction in those regions. So you'll have a patient presenting with a subacute memory deficit, which may also come across with confusion, agitation, depression, with other cognitive domains relatively spared. Seizures are quite common, and they tend to be focal seizures, but focal seizures with awareness impaired, and you can have hypothalamic dysfunction as well. And that's where you often find sleep dysfunction, hypothermia, and the endocrine-related symptoms. MRI, quite important, and it's sensitive more than 80%, but not specific to paraneoplastic pathology. So you can either have unilateral or bilateral mesial temporal lobe enhancement, T2 changes with flare changes as well. These lesions tend not to enhance. On the EEG, you'll have slowing that can either be focal to the temporal lobe, or it can be generalized slowing. And if you find epileptic activity, your best chances are to find it in the temporal lobe. PET scans show hypermetabolism in the medial temporal lobes in the early stages. In the late stages, you'll find hypometabolism, which is probably a feature of more destructive. Okay, that's just a picture of what we're looking for on the T2. So you'll see the two arrows pointing at an increased signal on the medial temporal lobes. So which tumors are related to limbic encephalitis? Lung, still the most common, small cell lung cancer. And the most common antibody associated to that is the anti-Hu, also known as ANA1. Then other tumors to look for is testicular tumors, seminomas, thymomas, breast cancer, and Hodgkin's lymphoma. So as I said, most common is anti-Hu, but also anti-CV2 and anti-CRMP5. But usually when they are present, their phenotype is more likely to cause an encephalomyelitis rather than a pure limbic encephalitis. Prognosis tends to be poor, and the treatment is more directed towards treating the underlying tumor. You can try immunotherapy. So the other important thing is if you catch the tumor early, it's less likely to have a presentation of limbic encephalitis later on. And the next type of presentation is if you have the brainstem involved. And it can either occur by itself or it can occur as part of a broader encephalitis, part of your limbic encephalitis symptoms plus brainstem, for example, or with cerebellar symptoms. We use the term rhombencephalitis when it only involves the lower brainstem. The symptoms to look out for: so oscillopsia, diplopia, gaze problems, nystagmus, opsoclonus, dysarthria, dysphagia, subacute hearing loss, central hypoventilation, vertigo. So those will be all brainstem symptoms. So if ever you have subacute onset of these symptoms, not finding a clear structural cause, then we must entertain this. Again, the tumors commonly associated, again, small cell lung cancer comes out on top, probably because it's one of the more common tumors. Again, testicular tumors, teratomas, thymomas, Hodgkin's lymphoma. So very same set of tumors that are causing the limbic encephalitis. In terms of phenotype, the anti-Hu tends to involve the lower brainstem first, and then progressively, rises up the brainstem, if you want to call it that, versus the MA2 antibodies start on top of the brainstem and spread downwards in terms of progression of symptoms. Again, as we said, poorly responsive to treatment, and again, treatment directed at the tumor. You can try some immunotherapy. The only exception to this is anti-MAR2 antibodies, whereas 1/3 improve. So not a large percentage, but a third is better than all the other paraneoplastic outcomes. The encephalomyelitis, that just implies it's affecting different levels of the neuronal axis, where you can have a sensory neuronopathy, cerebellar dysfunction, as well as brainstem and limbic symptoms. These patients will also have autonomic dysfunction. So that will present with postural hypotension, gastroparesis, neurogenic bladder, erectile dysfunction, sweating changes, rhythm problems with the heart, respiratory failure, etc. And you may also have chorea and uveitis with the CV2 and CRNP5 antibodies. Again, same story. Most commonly associated tumor is the small cell lung cancer, but in fact, you'll find cases of any tumor doing it, but it makes sense to start looking in the lung first. Again, treatment poorly responsive, and we try our immunotherapy. So now we're going to go the opposite way around. So instead of looking at the syndromes, look at the antibodies and what type of phenotypes they tend to cause. Anti-Hu, often when it is there, it can be entire CMS involvement, or you can have restrictive forms. As we said, small cell lung cancer, sometimes you don't find a cancer, but I think it should still raise clinical suspicion to continue looking even at set intervals. In children, you may find opsoclonus myoclonus. That tends to be associated with the neuroblastoma. And then also we have, in children, you may find it without finding the cancer as well, but that's a different sort of age group that we're looking at. And the most common cause of death in anti-Hu tends to be neurologic dysfunction causing brainstem symptoms with respiratory failure or hypoventilation. The MAR2 antibodies, normally seen in men under the age of 45, limbic encephalitis, brainstem symptoms. The common tumor is the testes, as we said. If you find this in the older men, you tend to look for other cancers rather than germ cell cancers. If it coexists with MAR1 antibodies, then again, lung cancer, again, very common, but outcomes much worse. The anti-CV2 and CRNP5, again, we've discussed this now, it can have a encephalomyelitis type of picture, also psychiatric manifestations with obsessive compulsive symptoms, and they can also occur with other antibodies, and again, small cell lung cancer, thymoma. Then we have paraneoplastic stiff person syndrome. So this is probably an isolated type of encephalomyelitis, and typically is associated with different antibodies. But in terms of paraneoplastic, it's the anti-amplifysin antibodies that are paraneoplastic versus what we normally see is anti-GAD and anti-glycine antibodies. Those are non-paraneoplastic. Okay, so that was paraneoplastic problems. Now we're talking about autoimmune encephalitis. We're looking at the neuronal surface and synaptic proteins, which are targeted by the antibodies. Here you can have a wide clinical picture, more common in females and children. And as we said, they may be associated with cancer, but the association is not that strong. They respond much better to immunomodulating therapies. The quicker we start the treatment, it improves outcomes, reduced mobility, speed of recovery, etc. So the most common type of autoimmune encephalitis that's currently documented is the anti-NMDA receptor encephalitis. And in this condition, psychiatric manifestations are quite common, movement disorders and seizures. The typical presentation would be that there's a viral prodrome, viral type illness a few weeks earlier, then you end up with these symptoms. But again, it has to be subacute. The clinical presentation, from a normal baseline, you have a subacute onset of symptoms. But sometimes you can have a pure psychiatric manifestation, and it becomes quite difficult then to think, is it psychiatry or encephalitis? They tend to have insomnia rather than hypersomnia. You can have, in terms of movements, involuntary movements, you can have quite a wide range of orofacial dyskinesias, dystonias, etc. And you have autonomic instability as well. So how to diagnose it? Serum has a lot. So if you do the serum antibody panel, there is quite a bit of false positivity that can be found. So the CSF is actually what is needed. So we do the antibody tests on the CSF. If you find in the CSF very specific, very sensitive, you will look for lymphocytic pleocytosis. But in the beginning, it can be early. So if you have a high clinical suspicion, you may want to repeat the CSF after some time. The EEG may show slow activity, and what's a classic sign, but not commonly seen, something called the extreme delta brush sign, which I'll show a picture of next. MRI can be normal, or you may find flare changes on certain sequences. You may also find contrast enhancement in the cortical and subcortical regions. PET is not a routine investigation done, but in research studies, it does show that there's an increase in the fronto-occipital. So they have a gradient from the front to the back of the head, and you can look at that gradient, and the worse the gradient is and the more severe the clinical picture is. But that's not routinely done. That is just a picture of what we call the delta brush sign, and that's just superimposed on a very slow delta background. As I mentioned, we look for the antibodies. Differentiating between IgM and IgA antibodies has no value. In terms of tumor association, in the females, there's quite a good association with ovarian teratoma. And the chances of finding that teratoma depends on the age of your patient. If your patient's more than 18 years old, there's a 50% chance you're going to find a teratoma, either unilaterally or bilaterally. And if your child's under 14, then the chances of finding a teratoma is a bit less. In the age group over 45, you're probably going to find a carcinoma rather than teratoma. But one should basically look for ovarian teratoma as a star, probably with the CT abdomen. Sonas does not seem to be sensitive enough. If you have a male with the same presentation, testicular germ cell tumors should be looked for, but normally no tumor is found. There are other reports of looking for teratomas in the mediastinum, small cell lung cancer, Hodgkin's, neuroblastoma in the kids, and ovarian cyst adenofibroma, but by far ovarian teratoma is the commonly associated tumor. There is quite and I think the literature is building up more and more on this, is that there seems to be an association with HSV encephalitis, almost like a post-viral complication. So 20 to 30% of patients with NMDA have actually there's evidence that they've seroconverted from HSV encephalitis. So they'll have a viral, so the typical presentations, I'll come in with an encephalitis, turns out to be viral HSV related, and then 2 to 3 weeks later, they have almost a relapse. But it's not a relapse of a viral etiology, it's rather than an autoimmune presentation coming up next. So even reports up to the symptoms coming up to 3-4 weeks later. So in general, when you talk about the presentation of NMDA encephalitis, there's a progression of symptoms, as you said, subacute, 4 weeks, even up to 6 weeks of progressive neurologic symptoms. And sometimes you have other antibodies associated, but that's maybe a byproduct or not the main cause of their presentation. We're looking at GABA A and the dopamine 2 receptors. Treatment, if you find the tumor and take out the ovarian teratoma, that seems to help quite a bit. But in general, immunosuppressive therapy, and starting with steroids, and then you've got polygam and plasma exchange. Which order to do that, which one is better, that's still debatable, but practical or pragmatic approach would be, give your IV steroids if your patient is slightly stable, no response, then you can either use plasma exchange or polygam, depending on what you're comfortable with. Without treatment, there have been cases of death. Patient can look quite ill. You can also have respiratory problems, ending up with a ventilator for quite some time. And as a next line of treatment, rituximab and cyclophosphamide have been shown to help. Prognosis, 50% will improve within the first week of a first-line therapy. So that was the steroids or the plasma exchange or the IVIG. And majority of the patients have a good outcome when you see them 2 years later. So this is probably a nicer condition to diagnose and to treat. You can have a relapsing type of presentation as well. And the other concerns of the antibodies crossing over to the baby, you have transplacental transfer of these IgG antibodies. The implications are uncertain, and maybe with long-term studies, they'll look and see if the kids with moms with these kind of conditions have any long-term issues. Then anti-LG1 encephalitis, they tend to present with memory problems, confusion, and seizures. And one specific type of seizure to remember is something called a facial-brachial dystonic seizure, because it actually looks like a dystonia. It's one of those cases where it's in between seizures and movement disorders. They do not respond well to the anti-epileptics. You can have hyponatremia and REM behavior sleep disorders as part of this presentation. MRI, you'll have medial temporal lobe hyperintensities, and the CSF can even be normal.
You can just show them what it looks
Exactly that.
You can just ask it out.
Yeah. No, she's just talking. It's just a video. She's not saying anything.
You mean there's no song?
Yeah, but if you just watch,
Look at the movement. Still coming. There was one. There we go. Yeah. That's flexion of the arm and
and the face as well.
flexion of the arm. Good. There we go.
So that's quite a clinical term if you see that.
Yeah, it's not better than the moment.
These are associated with thymoma. Again, tend to do well. Most of the patients will do well. 1/3 will have a relapse. Those who relapse do have a worse outcome. Anti-Casper2 can present with a limbic encephalitis, and you can have what's called a Morvan syndrome, much rarer. Neuromyotonia, sleep problems, autonomic instability, confusion, etc. These tend to happen in men more than 65 years of age and tends to have a slower disease course versus the others. So this is probably the exception where we talked about a subacute course. You're having an average of 4-month onset of progression, and in some cases even more than a year. Not usually associated with cancer. Most respond to therapy, and as you said, a few can relapse. Anti-AMPA receptor, majority are females in the sort of 50 to 60-year-old age group, limbic encephalitis with or without seizures. And here 2/3 will have a cancer. So this one has a stronger cancer association. The MRI usually abnormal. You'll look for abnormal CSF. And because of not being such a common condition, outcomes or prognosis is still quite varied in the literature. GABA-A GABA A is again another type of autoimmune encephalitis. Tends to be more rapid in terms of its progression. You can have refractory seizures. Patients may end up with status epilepticus or epilepsia partialis continua. About 50% in the kids group develop as a post-viral encephalitis and coexist with NMDA receptor antibodies. So again, this post-viral etiology comes back into play here. Again, I think in this group you have to go and look for tumors, and they tend to respond to immunotherapy. Then GABA B, seizures are common, encephalitis pictures, and 50% will have some sort of a paraneoplastic presentation with small cell lung cancer being most common. Anti-Iglon 5, so this is a more recently described antibody. Patients may present with parasomnias, either REM or non-REM parasomnias, sleep apnea, dysautonomia, bulbar symptoms, and gait problems. Here, video polysomnogram is helpful because you have to think about it. Sometimes it's quite difficult, and to diagnose it will be difficult as well because your CSF and MRI are often normal. Your patients tend to have a poor prognosis with this kind of condition. I'm not going to touch on anti-DPPX. Anti-glycine receptor. So this we mentioned it earlier. We talked about a stiff person syndrome.
Like Celine Dion.
So most patients tend to respond to treatment. Sometimes it's difficult, but you might have to find the right treatment, but there is a response. I'm just going to skip over. These are rare. You can see 5 patients described, etc. Okay. So when we're doing the antibody testing, there's a couple of things to think about. Number one is that if you see a clinical picture and you're worried about an encephalitis and you ruled out an infective cause, the next thing to do is to do the antibody testing, but you need to do it on both the serum and the CSF. And the other thing to realize is that if the antibody tests are negative, it does not mean that you've ruled out all causes of autoimmune or paraneoplastic encephalitis. And the reason is that not all antibodies have yet to be identified. So there's, each time they're identifying new antibodies and they update their panels, even something like the NMDA receptor antibody. Now he's talking about it being the most common autoimmune encephalitis, but this condition was only described in early 2000. So just bear that in mind. So sometimes your patient may respond to treatment even if you can't prove a specific antibody. And also your antibody test may be delayed. You may get your results a week later. So if you have a high suspicion, it's often warranted to just begin treatment while waiting for your results. And if you have, you can have different scenarios where you test both serum and CSF. If you have a positive serum but a negative CSF, possibly dealing with a false positive, then you may want to repeat testing to look for a change in the CSF. If you have CSF positive but serum negative, you can't continue with the treatment because that's more reliable. And you can use the antibody titers to correlate with the clinical response, but it's better to use a clinical picture rather than measuring antibody titers over time. And even if the NMDA, the patients remain positive for some time after even they clinically responded. So you don't look at the antibody persistence, but titers rather. And we don't have titers. We just have a panel that tells us whether you've got, variable, low positive, mid positive, and high positive. That's just summarizing the different syndromes, but I think in general, it doesn't make sense to go and remember all of this. If you see a presentation and you think it, you do the panel and then you can take it from there. With regards to limbic encephalitis, so there's actually set diagnostic criteria for this. So we see there's autoimmune and paraneoplastic causes, but for the strict diagnostic criteria, the presentation must be shorter than 3 months. There must be memory problems, seizures, or psychiatric manifestations. There must be bilateral changes on the MRI T2 or flare, and you must either have a CSF that's abnormal or an EEG that's abnormal, and have reasonably excluded alternative causes such as herpes simplex, etc. And then you can omit the last 2 points if you've got antibodies that are present. So you can make a diagnosis of limbic encephalitis even without the antibody test being present. Treatment, as we said, you begin your immunosuppressive therapy and you can concurrently look for your cancer. But most importantly, is rule out infective causes first. You treat symptomatically for the seizures. We'll try your best with the seizures. Sometimes it's quite difficult, especially with the GABA2 and GABA1. And then as a general point, I think we touched on this earlier, is that the paraneoplastic syndromes tend not to do well. Most of the time, the neurologic deficits are irreversible. And it's possibly because the pathology is due to T-cell mediated damage, whereas the autoimmune targets, the autoimmune encephalitis, are antibody mediated. So by removing the antibodies, by removing the B cells, tend to help the patient. After let's call it stabilizing the patient, using long-term immunosuppressive therapy, verdict is still out there, but most people tend to do it. So after you've done your plasma exchange, you'll tend to put your patient on either methotrexate as a thiopurine or something equivalent. At this point, there's insufficient evidence to say we should or we shouldn't do this, but I think most people would because the antibodies persisting in the CSF for life.
Yeah. Oh, thank you. This is really, very fun.
Yeah, so it sounds very complicated, but from a practical point, I currently have 4 patients with antibodies that are positive in some way that fit criteria. So we have anti-U with opsoclonus myoclonus syndrome that we're currently giving Polygam. We have an anti-Yo who received Plex. We have an anti-GAD who received Polygam. And then I have an anti-CD2 who I've just been sort of monitoring for many years. So they're actually currently
In the lady in ICU?
yeah, she's an anti-GAD.
Oh, yeah.
Yeah. So I currently have 4 patients with that. So they they are around. If you see a patient presenting for the first time with psychiatric manifestations at a later age, you have to think about it as well. And like, for example, one of the patients was actually sent by her psychiatrist, and he just said, you know, the patient is bipolar, but this is different from the previous presentations. This is very different for him. So he was actually concerned about an NMDA, which in retrospect wouldn't fit in clinically, but she is anti-Yo positive. So they're out there, and you just have to look for them.
Yeah, it's actually a point of debate in terms of psychiatric workup. So patients presenting with first onset psychosis and psychiatric symptoms, should all of them end up with a lumbar puncture looking for autoimmune? So the problem is they'll just overburden the system if that had to happen. But not a bad idea in some cases.
What is considered late presentation for psychiatric?
So basically like
Older, I mean. What,
no, so it's first presentations as well. So if you're a young female and
even if it's first.
yeah. So now basically when it's atypical, that's what tends to happen. But now the question is, should we push for, as part of your basic cycle, can we check your thyroid function? That's the question, because to say
It's not just HIV and syphilis.
yeah.
And lumbar function.
But that's more of a symptoms argument to say, no, should it be done or should
Yeah, do we have resources to do that?
Now we've realized you have to be very careful when you tell a patient that as part of the workup you're going to test them for syphilis, especially in the modern society. We've had a case where the family was very offended by us even suggesting that this might include part of the workup. So
I mean, we'll see that even with herpes, we've had mass panic because we've tested for herpes, but
when you're going.
No, so
Massive.
but massive.
Then you are the idiot. So if you don't taste it,
Yeah, just kind of to make it personal, say, listen, this is a standard workup. Any other doctor
I
can
showed them
continue the same.
my little book that, and I said, you see, I test all of my patients for
Yeah,
HIV
just for
and
parameters,
syphilis.
yeah.
And syphilis can also catch it out, and it's coming back. So you need to.
But I think that there's no substitute of not knowing. You know, the issue that I always say, every disease must have a name and there must be association. And if you actually don't know the name of the disease, you can't treat it. You can't deal with it. And I think one of the things, of course, which is for me is a strong learning point, because not small cell lung cancer can be just a tiny spot actually in the lung. And the problem that you won't be able to make any sense out of it. And most of the people probably just presented with neurological symptoms or sleep apnea and all those. So sometimes you might need to start from then going backwards. So it's very important that sometimes, I think this is what it highlights, that they have to be a kind of a multidisciplinary approach to a lot of medical problems. It's no longer like neurologists alone. You know, we have all kind of have to work together to get into diagnosis. So, and I think for me, that's what's really highlighted on this presentation. I think for me, it's really nice, amazing presentation. I learned a lot. There are a lot of things that I really never heard of. I don't know whether we test all of these antibodies in South Africa.
It's part of the panel.
Yeah, but I think we should probably, I think we must just increase our awareness to start testing and find. I think we always test what we know. And this highlight that probably we need to work close with each other and probably so that we can get the best for our patients.
It's actually amazing to realize that, as time goes on, just more and more testing is previously we just didn't know what was causing it. We just assumed it was some kind of autoimmune or some kind of viral. But now, with all the testing, we're refining the diagnosis and refining the treatment, which is actually amazing. But it makes my medicine very difficult, but also more interesting.
That patient of yours in ICU, she presented like a proper psych. If you had to eyeball her, you would have thought she's a psych presentation.
Still seems that way.
That's what you're based on. She's improved. So it does not change.
Yeah, neurologists are optimistic.
I'm saying, even after clicks.
But you know what? The only thing really clinically to examine her is she has a little bit of nystagmus and like broken saccades. So it's very subtle. And initially I couldn't even test that because she was so lethargic and just falling around and just this complete bizarre behavior, which I just thought that she's just having the second, like she's having the dip. She's now in the depressive part of the bipolar. So it can be tricky if the psychiatrist didn't push if he didn't push me and like.
So that psychiatrist studied in the UK. So a lot of he wants that kind of worker.
Okay.
I'm guessing maybe when most of
It's part of
maybe it's part of
Guys, people online, do you have any questions? This is quite very nice, interesting discussion. Please join us. Let's see whether there's any question online. Or comment.
I don't know if Inga is there. She saw the one patient when she came in.
Question,
It's
so
interesting.
it could be possible that in the past we've diagnosed psychiatric conditions.
very
100%.
very possible. So this NMDA story, I think they tell us 2005 is when we actually started testing in this country. When the antibody test became available. So the condition has been there the whole time, but you were only able to diagnose it after 2005
when you got the
and when you got the test done. So
Just that scary.
all before that, you were probably misdiagnosing them as whatever you wanted. Refractory.
Confidence, I mean, you just goes with confidence. Like I said, epilepsy before, when you get diagnosed with epilepsy, say no, you're possessed by a demon. So the priest can take over until people get to know it's epilepsy. And I think this is what's happening for reality now, isn't it? If you don't know, you just attribute it to something else.
What's the other patient you guys had? There's always in ICU every few months with the limbic encephalitis, autoimmune negative. Always has the T2 changes on the. They always put her in bed one.
Oh, yeah. I know.
Yeah,
She
so
passed away.
Yeah.
But I mean, so those are those things where she was refractory. Yeah.
She was extremely refractory in the end. But so it is unfortunately sometimes that you just can't reverse the
So even if you make the diagnosis, it doesn't.
But also,
But at least you know.
what I think we should just also be careful of is getting the false positives.
On the serum.
So it has to make sense. The syndrome needs to make sense. So for example, the patient,
Clinical misconduct.
yeah. So
Do you see a lot of cross-reactivity with the antibodies or no?
not really. It's not supposed to have like you're not supposed to have like CD2 plus anti-O plus etc. So you're supposed to have like one syndrome, preferably. Just one. Just one. But like for example, my CD2 patient. So it just never made sense because CD2 is supposed to give you like a proper like encephalomyelitis. But the only thing he actually had was like a temporal lobe epilepsy, which I never knew is this now or isn't it. But it ended up being something separate. So they're also allowed to have different conditions
at once.
at once. I mean, it's bad luck, but it just couldn't fit in.
Goodness, all new to me.
What I want to say from the casualty side is that these patients present with their mom and their dad, and then the patient has a complaint. It's just here for this headache this time. Then you see the funny little bruises and the things, and you worry about convulsions. And then the mom says, yeah, but he's been growing dippy. And then the dad says, not only that, he bumped the con. Then you get the history or complaint and casualties about 10, 15 things. And that is why sometimes from casualty side, we feel we throw you guys under the bus. Because I see something is wrong. But I don't know what.
You don't have enough information.
I get the odd white cell count, I get maybe a raised CRP, I get nothing in the urine, I get nothing on the scan. But then I need to ask you guys, because a list of 15 complaints is not something I'm going to quickly sort out in casualties. And that's why sometimes you get this phone call. Hi, Doc, I see you're on call. I just a moment to discuss a patient.
Oh, sure.
Because
It's 12.
I know something. I've seen 12 complaints and something's wrong, but I definitely don't know what it is. So from casualty side,
Well, that's a
I
difficult.
don't know how to increase our vigilance. No, that's what we
So basically what it's saying, neurologists, make you aware when casualty calls you, please help them.
But that is the kind of call you're going to get because
Exactly.
It is a
so it's one headache and 15 complaints.
15 other stuff.
I mean, as I say, most of the headaches, as we always say, psychogenic. Probably there's underlying problems, and maybe we don't know actually what caused it at the beginning. But I think as time goes on, more research become available, and we become more aware of the cell etiology because it's human body. We will never understand it, and that's the beauty about it. We will never ever be replaced by robots because you cannot substitute thinking with the AI. It won't work.
Thank you.
Yeah.
But that was nice. I mean, certainly from our point of view, it makes emergency medicine both extremely difficult, challenging, but also interesting because you get a little piece of the puzzle. And you could quickly dismiss it, send the patient home with a script. Yeah, and that's probably what GPs say the biggest challenge for GPs because they can't investigate. But some of these patients, as you go further, the book unfolds, and sometimes it's surprising where you end up, and it actually makes you almost looking forward to the next time your patient. You must just make sure you've got enough sleep the day before, because it takes a lot, but it's very interesting and also very rewarding at the end.
Yeah, I agree. I think I'm enjoying the presentation. I think I'm learning a lot. I don't think that we should always limit ourselves to know certain things. I think it's better to really, understanding a lot of diseases that require multidisciplinary. I think I enjoy it. Thanks, Kisten.
The only other thing is the cost of the workup. So with the better patient with anti-Euro, I think you saw that at some point. The Indian lady with the cerebellar ataxia. So like you do the entire workup and there's a high risk malignancy workup. You find nothing. Nothing. She doesn't respond to anything. Plasma exchange. So you end up taking out the room just because you've got nothing else to do.
Yeah, but sometimes when you find nothing, that does not mean that there's nothing, but at least you have done your part. Just because I always tell patients with the provoked pulmonary embolism, say, listen, most of our tests are limited, but we can't test more. And that's why it's probably in South Africa is a need to have a research kind of lab. Means basically, I think we have one in Porch, but looking for storage diseases. But it would be nice to have one actually looking at let's say, those antibodies that patients that are negative. So maybe then you must look for something new, you know,
Or
because
just store it for
exactly.
a specific
But I
stage.
just think there's need for that. We should always not kind of be dejected and saying, okay, we can't find anything and throw your arms up. And I don't think that should be cool. I think we should go extra miles and maybe perhaps even send some of the specimen that the patient can afford. Most patients can afford, and most of those tests are not expensive. And you could actually send some of these specimen to Oxford or to Mayo Clinic, and you could get much more detailed testing. So I don't think we should stop before. You know, I think give the patient that opportunity and then see, even if you find a diagnosis and it's untreatable, but perhaps it's a link to the family members, you know, because patients never come out from the tree, they have their roots. And then maybe you could, in future, if even though the demise, I think the family, the children, whatever, they'll understand that they have those problems. And as time goes on, the disease treatment become available.
That's also an important point because I'm seeing a patient currently, and it's for Fred. And when I looked at this, I saw her for a small fiber neuropathy, but when you look at her, you can see she's dysmorphic. And I asked Fred, okay, so what's the syndrome? And then I went back and realized that she's been seen for years and years. There's no syndrome diagnosed, but you can see she has like some chromosomal abnormality. And then the sister walks in, and I'm like, dude, how did everyone miss this? So they definitely have some kind of chromosomal abnormality, but there's no diagnosis. She's seen another neurologist at a different hospital. I found him. He said, no, he's in genetics, but it's part of a it's part of tax. It's Van Cooler, so the sister. So it's a study. So there's nothing. And then I spoke to him. I'm like, don't you want to know what your children have? Because I mean, you know, look at them. And then she's like, sure. They just send me to the geneticist. So I mean, sometimes you just have to like send them where they're supposed to go.
I think I remember once, I think in the pits, we have this child that looked dysmorphic and we were very concerned. So we asked the mother about that. Then mother said, no, you look cute like his dad. No, but I agree with your point. It's going extra mile, but have a look at the father.
But remember that for those parents, when they grew up with children, so they don't notice it. They never looked at movie about me, myself, and my read. When the children, don't you notice your children's got like all year round tan, you know? It's it's like
Definitely. But that mother especially, I mean, she then I said, but they're both living with you, they're like 30 years old. Don't you think that's abnormal? She's like, yeah, but she's used to it. So it's
I love them.
yeah.
My house is open.
Yeah, and then I do a marker and it goes like 15 out of 30, so there's cognitive
Then
impairment.
maybe it's a
So
virus.
there's a lot of stuff happening, but
Give him something called Ravendran.
yeah,
Yes, that's normal.
just know it's a new normal for it.
Yeah.
All right, guys.